All right, let's get you exam ready for one of the most challenging cases out there, anesthesia for a pediatric renal transplant. We're going to cover everything from pre-op to post-op, hitting all the high-yield points you need to know. So why all the fuss? Well, it all comes down to this number, 99.5%. That's the incredible one-year graft survival rate we're all shooting for. It really shows you how every single detail, especially on our end, is absolutely critical to the puzzle. So let's dive in. Okay, here's our game plan. We'll start by looking at the patient themselves. Then we'll walk through the pre-op assessment, map out the anesthetic plan, hit the critical moments in surgery, cover post-op care, and then wrap it all up with the key takeaways. Right. First things first, the patient. We really have to understand who these kids are and why they need this surgery. Honestly, their underlying physiology is the foundation for every single decision we're about to make. So what's causing their kidneys to fail? Well, it really depends on their age, and this is a key distinction. For the really little ones, under 5, you're pretty much always dealing with a problem they were born with, something structural. But in the older kids, the story shifts, and you start seeing more acquired problems, like glomerular diseases. Knowing this is super helpful because it gives you clues about their overall health. So when do we actually pull the trigger on a transplant? The criteria are pretty clear. They got to be over 6 months old, more than 10 kilos, and their GFR has to be in the basement, below 15. But here is the golden rule, the high-yield fact for your exam. The goal is to do the transplant before they even need dialysis. This is called a preemptive transplant, and the long-term outcomes are just way, way better. All right, let's talk about the preoperative assessment. And look, this is so much more than just ticking boxes. Think of it as drawing up the battle plan for the entire anesthetic. Getting this right is everything. This checklist right here, this is your absolute safety net. Every single point has major implications. For instance, you have to know when their last dialysis was. Why? To avoid any leftover heparin and a huge bleeding risk. And knowing their fluid targets, or if they're even making urine anymore, that basically writes the script for your entire intraoperative fluid plan. And this is so important because it reminds us we can't get tunnel vision on just the kidneys. These kids often come with a whole package of other issues tied to these syndromes. You see prune belly syndrome on the chart? You better be thinking about their heart. Barter syndrome? You should be thinking about wacky electrolytes and arrhythmias. Spotting these is absolutely key to not getting caught by surprise. Okay, investigations. These are your non-negotiables. The bloods are going to tell you about anemia, which is super common, and most importantly, that potassium level. The ECG and the echo, they're like our window into how the heart has been coping with years of stress and hypertension. It's all about building that complete physiological picture before we even start. Now, get a load of this statistic. Up to 80% of these kids are hypertensive. And that's not just some random fact. It's a huge deal for us. Why? Because that chronic high blood pressure messes up their body's own automatic blood pressure control. So when we give our anesthetic drugs, their pressure can just fall off a cliff. We have to be ready for that. So with our assessment done, we've got our intel. Now it's time to actually build the anesthetic plan. We're talking drugs, devices, the whole shebang. The setup here is all about control and being prepared. An arterial line is completely non-negotiable for that beat-to-beat blood pressure. And check out this pro tip about the central line. We aim for the left internal jugular. Why? To save the right side for any future dialysis access they might need. It's that kind of forward thinking that really defines expert care here. And we're in the OR. Let's break down the key surgical stages. Because if we know what the surgeon is about to do, we can get ahead of the massive physiological swings that are just around the corner. So what are the big, scary moments? Well, for us, you can really boil this whole complex operation down into 4 distinct phases, and in each one, our goals and the potential challenges are totally different. And this is the playbook. Step 1, during dissection, we just keep things steady. But then, step 2, right before those clamps come off, we start to fluid load. We get ahead of the game. Because step 3, reperfusion, is the main event. We are expecting a massive drop in blood pressure, so we're ready with fluids and pressors. Finally, step 4, closing. Now we just maintain that pressure and stare at the urinary catheter, waiting for that beautiful sight, the first drops of urine. Let's just zoom in on reperfusion for a second, because this is the moment of highest risk. Make no mistake. The second those clamps are released, the new kidney floods the body with this cocktail of inflammatory chemicals that make the blood vessels relax. The result? a sudden, dramatic drop in blood pressure. Being ready for this is probably our single most important job. Phew. Surgery is over, the new kidney is in. But our job is not done, not even close. The immediate post-op period is absolutely vital for making sure this all works out long-term. For pain control, there is one golden rule. Protect the graft. That means NSAIDs, things like ibuprofen or ketorolac, are completely off the table. A total no-go. They can reduce blood flow to that brand new kidney. So instead, we use a multimodal approach. Paracetamol, opioids, and really effective regional blocks, like a TAP block. Post-op, you have to be a hawk. These are the red flags. And if you see one, especially a lack of urine output or sudden hypotension, that could be a major problem, like a clot in the new graft's artery. This is not a watch and wait situation. This is a call the surgeons back stat to save that kidney. Okay, we've covered a lot of ground. So let's boil it all down to the absolute must-know points for your exam and for safe practice. If you remember only one single thing from this entire explainer, make it this. What you do in those few hours in the OR, how you manage fluids, how you maintain blood pressure, has a direct, lasting impact on how well that new kidney works for years to come. What we do matters a lot. So here it is, your core mission in 4 points. 1. Optimize their fluid status. Not too much, not too little. 2. Maintain their blood pressure relentlessly. 3. Anticipate that reperfusion drop. And 4. Protect the graft with a smart NSAID-sparing pain plan. If you master these 4 things, you've got this. This explainer was based on the anesthesia tutorial of the week on pediatric renal transplants. To really lock this in, I'll leave you with a question to chew on. What's the biggest physiological challenge you'd expect when anesthetizing a small 15-kilo kid who's getting a big adult-sized kidney? Pondering that scenario will really solidify your understanding. Hope you found this helpful.